Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Lake Superior Quality Innovation Network webinar. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Jerry Henniker. Jerry, the floor is yours.
Thank you, Erin, and again, welcome everyone to today's webinar on health literacy by the numbers. Today's webinar is brought to you by the Lake Superior Quality Innovation Network. The Lake Superior Quality Innovation Network is made up of 3 quality improvement organizations: MPRO in Michigan, Stratus Health in Minnesota, and Medistar in Wisconsin. Together, we provide collaboration to improve health care for Medicare consumers, share best practices, and maximize efficiencies. The slides for today's presentation will be available on the LSQIN website after the webinar. And as previously mentioned, we will be taking questions at the end of the webinar, but we would also like you to feel free to use chat during the webinar if you have questions, and then we'll also get to those questions at the end of the webinar. With that, I'd like to introduce our speaker for today. Alicia Elwood Odiambo is the Senior Provider Quality Program Manager for Blue Cross and Blue Shield of Minnesota, where she is responsible for managing provider incentive quality programs, clinical quality improvement projects, and developing and promoting health literacy activities. Alicia serves as chairperson of the Minnesota Health Literacy Partnership, a community collaborative focused on improving health for all through clear health communication. Alicia, the floor is yours.
Great. Thanks, Jerry. Welcome, everyone. It's my pleasure to be with you all today to talk about health numeracy. I just want to make sure people can hear me, and you probably can't respond, but if someone notices that they can't hear, please chat or something if you feel like the connection isn't working. Health numeracy, as you may have gathered, deals with quantitative information or numbers instead of or in addition to words. Just like health literacy, health numeracy can significantly impact a patient's decision-making, outcomes, and overall health. That's why we're going to talk in depth about numeracy aspects and health literacy together and go over some strategies you can employ to bolster your messages about dosages, treatment decisions, risk-benefit communication, and much more. After today's session, I hope that you'll be able to define health literacy and health numeracy, explain why health numeracy matters, and understand strategies for using numbers, if at all, in patient communication. So we'll start with what is health literacy. Health literacy is our ability to read, understand, and act on health information. And this is facilitated by us as health professionals through our ability to communicate clearly, educate about health, and empower our patients. Health numeracy, then, is an aspect of health literacy that includes the quantitative skills necessary to understand and act on numerical directions given by healthcare. Or in other words, you can consider this our ability to access, interpret, and use quantitative information or numbers to manage one's health. The key words here are access, interpret, and use. These concepts should be kept in mind whenever we are delivering a health-related message, whether it be directly to a patient or to their family member, advocate, or interpreter, whatever it might be. It also applies to communication materials such as decision aids, pamphlets, websites, signage. Remember that communication is always a two-way street. Both the patients and healthcare providers have roles in the impact of health numeracy. So when might a patient need to use their numeracy skills? The applications are broad. Patients use numeracy when they research health conditions, receive healthcare services, follow medical advice, pay for medications, take medications. Some examples are, being able to take your medication correctly, making treatment decisions based on risks and benefits, understanding safe ranges for blood pressure or glucose levels, reading food labels, making medical appointments, and we could probably go on and on. It's just hard to think about health and health care without thinking about numbers. Numerical concepts might include more basic skills like counting and arithmetic, or analytical concepts like percentages, inference, or even more advanced cognitive demands like understanding relative versus absolute risks and reading tables and graphs. Sounds pretty important. Why else does health numeracy matter? Not only is numeracy crucial in those specific examples we just talked about, but it also has implications for whole populations. Lower health literacy and numeracy are linked to shorter life expectancy, poorer health outcomes, higher incidence of ER visits, higher rates of readmissions to the hospital, and low numeracy in particular has been linked to poor medication adherence and poor management of chronic diseases, including glucose control, asthma monitoring, and anticoagulation control. As you may have guessed, numeracy is especially important in managing diabetes, asthma, and heart disease. We also see higher comorbidity and higher BMIs in those with low numeracy skills. Recent studies even suggest that racial disparities in chronic disease contexts, such as poor glycemic control and diabetes, can be blamed on low numeracy as much as low health literacy. The same is true for patients with a history of hospitalization for asthma. Further, as the emphasis continues to shift towards shared decision-making in healthcare, numeracy becomes increasingly relevant. Patients need to understand concepts like risk in order to be empowered to make the best treatment decisions for themselves. And thanks to the internet and the rise of electronic information, there's more quantitative information than ever for patients to sift through. So just how big of an issue is low numeracy? Over half of U.S. adults struggle with numeracy. It's also important to remember that even those with adequate or above average literacy skills can still have trouble with numeracy. Numeracy and education are related, but they are not synonymous with one another. Several studies indicated that plenty of doctors even had a hard time correctly answering questions about relative risk and other mid-level numerical concepts. Many people are turned off by numbers. I'm sure you've heard folks say, I'm just not a numbers person. Many people experience very real math anxiety when they are confronted with numbers. Add that to the illness, pain, and stress that often accompanies a visit to the doctor, and you've got a recipe for miscommunication. It's important to also keep in mind that patients who are older, less educated, non-English speaking, and of low socioeconomic status are at greater risk of having low health literacy and low health numeracy. You will undoubtedly come face-to-face with insufficient numeracy at some point, if not already, on a regular basis. That might sound grim, but the good news is that there are steps you can take to increase the effectiveness of your communication, even if numbers have to be involved. For starters, understanding how patients learn and how they do not learn can take some of the guesswork out of health communication. We're going to talk briefly about data processing, decision-making, and the importance of underscoring the gist of the message that you're trying to deliver. As science-minded folks, many of us may take for granted that we are steeped in data and numbers every day. But how does data look from a patient's perspective? As mentioned, the first sight of a number or graph can rekindle math anxiety in patients. It can also distract from the take-home message. At worst, it may alienate patients from a conversation about their own health. There absolutely are instances when data and numbers are a necessary part of the conversation, but knowing when not to use numbers is just as important as knowing how to use them. Are you trying to explain the risks and benefits of a treatment option? The numbers demonstrating the magnitude of the risks involved will likely be necessary. Are you talking about health promotion or screening? Perhaps a story or anecdote would actually be more effective. The key is reducing the cognitive burden for the patient as much as possible and focusing more on the potential outcomes and actions that the patient will likely understand and remember. Has anyone heard of the curse of knowledge? Psychologist Steven Pinker defines it as a difficulty in imagining what it is like for someone else not to know something that you know. Basically, once we know something, we find it hard to imagine what it was like not knowing it. Think about something that you know how to do now, maybe like riding a bike. It's hard to remember what it was like to struggle to keep balance and remember to keep those pedals moving. Now you just get on and ride. This can be problematic when speaking with patients because we might casually throw in statistics, percentages, or medical jargon, despite the likelihood that the patient isn't familiar with these concepts. But for many patients, this kind of information overload triggers a cognitive shutdown, and instead the patient may come away with nothing, or even the wrong message. It can also make the provider seem condescending or apathetic, giving the patient even less incentive to listen. If we put ourselves in the patient's shoes, we can see the importance of providing context and clarity when communicating with numbers. Now I want to talk about a concept called the fuzzy trace theory. The name sounds funny at first, but the concept explains how people learn things, access memory, and make decisions. According to this theory, there are two modes of thinking when it comes to processing information: verbatim thinking and gist-based thinking. Verbatim thinking is just what it sounds like. A person stores and recalls exact facts and details, such as numbers. It is deliberate and precise. The second mode, gist-based thinking, is vague. It tends towards the relational and categorical. It is quicker and intuitive. It turns out the vast majority of people and patients rely on gist-based thinking to make most decisions, and even to recall childhood memories. It is the default mode of tracing information in the brain. Here's where the puzzing part comes in. We rarely remember every detail of a conversation or experience. We instead retain the gist of it, and our brains construct the rest of the context from a mixture of emotions, past experience, and even our worldview. When we're given a slew of information like statistics and medical jargon, the brain automatically strives to extract a simple, one-note meaning. People tend to fully accept or fully reject a notion based on their first impression and combine that with their gut feeling. If we aren't careful, patients might arrive at a very different bottom-line message than the one we're trying to get across. In fact, it's quite possible for a person to recite the numbers and details of a conversation correctly, yet still fail to derive the intended overall meaning. Information must therefore appeal to the gist-based intuition first in order to stick, particularly when trying to motivate a patient to take action. So instead of opting for the more information is better approach, think first about bridging information and action through gist-based messaging. Develop a preliminary message that hones in on the outcome or action, then reinforce that data carefully and only when necessary. So what might this look like in practice? Let's look at an example. Mr. Fisher arrives at the hospital with moderate chest pain after ruling out a heart attack. His doctor tells him this: "Well, Mr. Fisher, your systolic blood pressure is 150 and your diastolic is 95, indicating primary hypertension. You'll cut your risk of heart disease by 50% if you can quit smoking. We could also get you on 25 milligrams of beta blockers once a day. What do you think about that?" Of course, Mr. Fisher feels overwhelmed. He's at the hospital alone and very anxious after the heart episode. He's thinking, what was that, about 25 pills a day? Or was it 50-something? How might the doctor have delivered the messages more effectively? Here's a step in the right direction. The doctor can start with the gist and then circle back to reinforce with numbers. So, for example, Mr. Fisher, your blood pressure is high. If you quit smoking, you can cut your heart risk disease in half. There are also medications that can help. At the very least, the doctor can pause, like I just did, between the different statements and concepts. Better yet, he could break these very different ideas, test results, diagnosis, recommendation, medication, into separate segments, and ideally devote chunks of time for each instead of mashing them all together in one sentence. This will help to underscore gist for each topic, reduce the cognitive load on Mr. Fisher, and emphasize the actions. For instance, when he's talking about blood pressure being high, he could go to a visual aid or chart that shows where Mr. Fisher's blood pressure is on a scale, giving the information some context. Using numbers with patients. What about when qualitative descriptors or those stories and anecdotes just won't do? Sometimes you just need to use numbers. Fortunately, there are ways to reduce the likelihood of misunderstanding or information overload for the patient. A lot of the tips we've talked about and we will talk about revolve around a common goal, reducing that mental effort or cognitive load required of the patient. This concept is common both in health numeracy and in health literacy, and it can increase comprehension and retention for patients. The chart before you shows a hierarchy of numerical complexity. You can see how many numerical skills are relevant to health communication. You need to read numbers on prescription labels. Telling time helps you keep on time and be on time for appointments. And whenever possible, we want to tend towards the basic elements of numeracy, so towards the top of the scale in the chart. Remember, over half of the population has only basic or below basic numeracy skills. Stay on the safe side and assume that your patient will struggle with numbers. A good first step when thinking about numbers is to ask yourself, why are you using numbers in the first place? Is it to increase knowledge, provide instruction, help with informed decision-making? Are you trying to persuade or motivate your patient? Thinking about what you hope to accomplish will help determine which numbers to use and how they are presented. You can make that why the focus of your preliminary message, and then incorporate numbers for emphasis. The order of the information might be your next consideration. Always start with the most important information first, since that's what will make the strongest impression. When using multiple figures for comparison, put them in a logical order so that they're easier to digest. This might be by date, perhaps if reviewing recent medical events, or simply alphabetically, depending on the context. Note that when the biggest number represents something bad, or it's at the end of the spectrum that you want to highlight, consider using a descending order because it puts the most important information first, but still keeps a logical order. This could be useful also when discussing something like the most common side effects of a treatment. Health information does not have to be exhaustive, meaning we don't have to share everything we know about an illness or condition. As mentioned before, it's best to keep your message direct, actionable, and specific. But when covering complex concepts, that might be harder to do. Think about trying to focus on one idea at a time. Breaking communication into chunks and grouping them logically will make them easier to receive. And always, remember to underscore the gist of each piece. Let's get specific and talk about rounding. Rounded numbers are friendlier numbers. Whenever possible, round your numbers so that they are easier to understand, compare, and recall. Instead of using 78.64%, maybe use 79% or even 80%. Which one would you be more likely to remember? Do they still give you the gist of what you're trying to explain and convey? When you round, what you're actually doing here mathematically is keeping the denominators or the scale consistent. This practice is also recommended when using frequency comparisons. For instance, don't compare a 1 in 10 chance to a 1 in 5 chance. Instead, frame it as a 1 in 10 chance versus a 2 in 10 chance. Then the patient is comparing 1 and 2 versus 1/10 and 1/5. For many patients, a 1 in 5 chance actually seems less likely, even though it's actually twice as likely as a 1 in 10 chance. Remember the chart that we were just looking at with the hierarchy of numerical elements? If we want to tend towards basic math skills, it's important that we do as much of the math for the patient as possible. Instead of telling a patient that 10% weight loss will greatly improve his health, tell him that you recommend he lose 20 pounds. You can also point patients to online tools or calculators if the patient will be expected to manage a chronic disease at home. There are calculators that you can use for insulin doses or carbohydrate tracking, Of course, be sure that they are comfortable using tools before depending on them. In addition to listing dosages on a medication label, physically marked medicine cups and syringes with a permanent marker to take the guesswork out of measuring. Pill cards can also be helpful for doses and scheduling. It's amazing how, you might not think of those as being numerical concepts or places where patients need to use numbers, but it is evident that all of those things do have a number component. Visual aids can also be helpful when you're talking about numbers and trying to clarify concepts. Visual aids like diagrams, charts, and graphs can enhance health communication by reframing messages. They take into account different learning styles and preferences rather than relying on one type of information delivery like verbal. They can also convey gist-based information while including details. A doctor might draw a thermometer demonstrating what a high temperature looks like. A dietitian might use a visual analogy comparing a serving of cheese to a pair of dice or a portion of salmon to a deck of cards. There are visual tools like the My Plate icon that indicate how much of certain foods we should eat. Visual cues included things like highlighting relevant information on a lab report to show results that are out of the normal range, so highlighting things, circling, writing it down. I was listening to NPR a couple of evenings ago on the way home from work, and they were interviewing a physician about the new breast cancer screening guidelines. He began talking about how difficult it can be to try to explain the numbers around risks and benefits of mammograms to patients. And he mentioned that he always uses a visual aid to help him walk through the details with his patients. In the right situation, graphics can clarify and reinforce communication, as well as add interest and keep patients better engaged. These visual representations work best as supplements to the primary messaging and should not be relied upon without the proper explanation. Keep this in mind when giving patients handouts that contain graphics and numerical concepts. Something like this icon array might be new and confusing without an explanation or a written summary. And remember that they might be bringing it home to a spouse or caretaker who will have to interpret it but didn't get the benefit of your explanation. Narrative support can provide further context. Connect the abstract to the concrete and humanize numbers. Think of how impactful and anecdotal evidence can be. For example, how people flock to the store for the latest miracle cure after it's featured on an episode of Dr. Oz, despite little to no credible evidence of its effectiveness. For instance, to illustrate how a patient can fit 30 minutes of walking into her day, you might use the example of a woman who takes shorter walks 3 times a day after each meal. To put smoking risk into perspective, explain that the total number of deaths from smoking in the U.S. each day is equivalent to 2 jumbo jets crashing every day with no survivors. These visual concepts help bring numbers to life and have meaning for patients rather than staying abstract in just a numerical form. Patients will relate to and remember these stories better than the cold, hard data. Also consider any cultural barriers that might affect the patient's ability to comprehend your message. Ask which measurement system they use. Do they prefer U.S. standard or the metric system? What about subtle differences in word meanings or connotations, colors, symbol interpretation? These can vary between different racial and ethnic groups, as well as between generational cultures. For instance, you might want to use the color red to represent the high end of a blood pressure scale. In the U.S., the color red often symbolizes danger or stop, while in China, it can stand for luck. If we want to reduce the cognitive burden placed on patients, it does no good to cloak our simplified numerical concepts in medical jargon. Unfamiliar terminology is distracting and alienating, so don't use it unless you really need to. With all the effort that you put into trying to make your numbers simple, if you surround it by jargon, your effort is lost, so don't waste that effort. For example, instead of saying contraception, say birth control, replace words like orally with by mouth. I cannot emphasize enough the importance of using plain language with your patients. Barring a request for further insight, only provide as much background information as is necessary. This may go against your natural tendency, but as we talked about before, we need to give patients what they need to know right now to understand the concepts to move towards outcomes and actions that are relevant. Finally, always check the patient's comprehension of your message before they leave your office, especially when numeracy is a factor. This can be done efficiently and effectively using the teach-back method. You may have heard me talk about the teach-back method before. Teach-back involves having the patient repeat back to you in their own words what you discussed. Use phrases like, I want to make sure I explained everything correctly. Please tell me how and when you plan to take this new medication. You might ask how they plan on telling their spouse, their partner, their adult child what happened at the doctor's office. Make it clear that it's your ability as the communicator being tested and not their aptitude or ability. It's best to use open-ended questions, like some people feel dizzy when they start this medicine. Tell me what you would do if that happened to you. Have them demonstrate how they would go about troubleshooting. What about this one? If you miss a dose of this medicine, what will you do? So the idea of how or what helps you form those open-ended questions. And lastly, avoid the yes or no easy questions like, do you understand? Or will you be able to calculate your insulin dose on your own at home? The patient will likely feel embarrassed if they don't know and probably just say yes. So let's revisit the idea of visual aids and data visualization. We talked about this as being an important element of getting numbers and concepts across. We'll go over some guidelines for appropriate and effective presentations. A picture may be worth 1,000 words, but that's only useful if they're the words we're trying to get across. Here we have a graph showing potential side effects of a treatment. The chances of the side effect increase as we move to the right, and the severity increases as we go up. The size of the dots indicates their likelihood of occurring, and their color indicates their severity. We see percentages and text among the symbols. While you or I might be able to look at this graph and garner some useful information from it, to a patient, it could very well be confusing and not intuitive. There are multiple symbols, position, size, colors for each variable, and the descriptors could cause additional confusion, if not alarm. So true or false? Images like infographics are easier to understand than a paragraph of plain text because pictures don't require literacy skills. False. People read images too. Charts, lists, graphs require document literacy skills. Document literacy skills tend to be even lower than general literacy and numeracy skills, especially with charts, tables, and graphs. Document literacy is the ability to search, comprehend, and use non-continuous text, so not paragraphs or things like you'd see in a newspaper, but information included in charts, food labels, diagrams, schedules, and so on. This can be challenging for even skilled readers. There's the curse of knowledge again. We likely use these tools every day, so we take these skills for granted. But that might not be the case for your patient. Think about what it takes to use a table. You have to understand the concept of rows and column headings. First the row and the column that pertains to your interest. Locate the cell where they intersect. Scan up and down and back and forth until you have found what you needed. Perhaps you're trying to calculate how much medicine to give a child based on their weight, age, and whether you're using tablets, capsules, or an oral suspension. I searched dosage chart for Tylenol and found some examples of this. It entails finding the child's weight in the correct units in one column, their age in another column, and matching one or both columns to the dosage options across the rows. Even I found it confusing to find the right dosage. Using charts is likely second nature if you're used to it, and certainly not impossible if you're not. But it will take more cognitive demand for the patient, especially if you're also throwing numbers in the mix. Keep this in mind when deciding how to present information, especially if graphs are involved. Here are some tips to make your visual data less challenging for your patients. First, Simplify. Stick to one message per graph or chart. Stay away from having too many categories whenever possible. Remove or de-emphasize grid lines, borders, and tick marks when they aren't necessary, or they'll just create visual noise. Don't be afraid of white space. It can help charts and graphs to feel less overwhelming. If putting numbers for comparison next to each other means having a lot of white space, don't move them apart just to fill the page. Keep them close together. Avoid fancy distorted graphics like 3D lettering, bubbles, and embellishments. I just popped up the chart. Sometimes this pops up while I'm talking, and I just think this is a really interesting graphic because this does not seem like an intuitive way to put together a calendar. It's hard to tell which day is falling in which month or which week. So this is a funny example of trying to cram too much information or use a new and innovative way to explain something that has been tried, proven. This would not be my first choice for a calendar. After you simplify, which we just talked about, then clarify. Make sure your chart or graph is audience appropriate. If your patient demonstrates very low document literacy, health literacy, numeracy, find another way to convey the information. Use the appropriate order. We talked about descending, ascending, by date, alphabetically. Use what makes sense with the data that you're trying to convey. Keep scales intuitive and consistent whenever possible. Use the same time frames across data. Use the same denominators across data. Make sure that the chart is complete enough to stand alone, especially if it's part of a handout or an aid that the patient will likely be taking home. Underscore the gist of the graphics by writing it on the bottom or the top. Tailor it so that it pertains to the patient. Highlight or circle the parts that are relevant to them, calling out things that are important. For example, their blood pressure rate. This isn't a perfect example, but they did a good job of customizing it with the patient's information. You'll see where this person's blood pressure is at 170. Adding a few sentences about what action is needed would make it better. Think about how you're using text within your visualization. Consider right justifying numbers and tables so that their difference of magnitude are more apparent. Be very clear to tell the difference between 1, 10, 1,000 if they're all right justified. Make sure your font size and typeface are adequate and clear. 10 to 14 points are good size, though consider larger overall formats for those with poor vision due to factors like age or eye disease. Use simple, clear fonts, particularly for charts and graphs where space for text is often limited. It's best to use the no-frills fonts like in Arial fonts. Keep access labels and legends clear and concise. The graphics should also always have a title that briefly explains the who, what, and when of the chart or graph. Notice that this graph is missing a title. A suggestion might be Mr. Fisher's blood pressure score and relative risk of heart disease. And then the date, so if it was taken in August or when that might have happened. Note that the legend shows risk increasing with the size of the circles. This could also use a little bit more explanation because I'm not sure that a patient would get the arrow and the greater circles meaning higher risk or more risk. Also, the font could be a little bigger. It gets a little small with this chart. A few words about color. Avoid using images in the background. Instead, keep it white or very subdued. This helps to assure adequate contrast, which is very important. Here, you'll see the number 53 is yellow, and you can see why they did that because it corresponds to the moderate risk. However, the yellow is harder to read against the white background because there's not as much contrast with the white. If colors have meaning in your visual aid, make sure that the shades and hues with different meanings aren't too similar. make sure that the patient understands what the meaning is, and you don't just leave it up to their intuitive knowing that, one color is better than the other color. If the image is online or in an email or used for making copies, you might consider a black and white or grayscale to avoid inconsistencies and color calibrations with monitors. Color blindness is often forgotten too when we think about choosing color schemes for graphics. There are tools at colorblindness.com or I think colorbrewer2, the number 2.org that offer colorblind friendly palettes. So, be sure to think of those. And finally, consider using action colors to highlight pieces of data or to indicate meaning. So we were talking earlier about how red is often used for bad or for danger, while green is universally kind of considered good. Keep in mind, though, that not all colors mean the same with all cultures. With these formatting tips in mind around color, type, size, fonts, here are some other guidelines. Remember to keep the gist in mind when deciding if and how you're going to display information visually. The chart or graph should supplement your take-home message and help you explain numbers and numerical concepts that you're trying to get across. One way to visualize numbers is by using a pie or donut chart. These are probably pretty familiar. They display parts of a whole that are related to each other, allowing for easy comparison of proportions. This presentation format is good for highlighting the smallest or largest piece of a whole, such as the most common side effect or least common treatment choice. All of the pieces represent a percentage of a pie, and they add up to 100%. You may have also seen the donut chart, which we saw on the previous slide, which has the hole in the middle that is often used as a space to call out an important percentage of the pie. Some other do's and don'ts about pie charts. Okay, obviously this isn't a health-related pie chart. It's humorously based on the lyrics of the 87 Rick Astley hit, Never Gonna Give You Up. But I used it because it actually does a lot of things right. There's a title. The labels would be too long to superimpose on the pie, so there's a reasonable legend instead. There are not more than 6 slices. The slices are oriented in descending order, going clockwise. A couple things that could be changed here to make it even better is that the largest slice should be oriented at the 12 noon. So that large kind of purplish blue slice should actually be moved over, and the whole pie should be turned a little bit to the right. And then the other thing that was bothering me when I looked at this is that the salmon color seems to be used twice. So you want to make sure that you have color variation if you're trying to show different sections of a concept. Bar graphs are another option that you can use. Bar graphs are rectangles or bars that each represent a group of data. The axes allow for display of different classes and values. Bar graphs show relative differences or patterns between and across groups for easy comparison. So here you can see 7 or under age group, 8 to 16, or the over 16 age group. They may be vertical, as with this graph, or horizontal. Vertical bar graphs are better for showing comparative rise and fall of values. Horizontal bar graphs are better when longer text labels are needed for the groups. That way they can be placed in an easier to read position and don't have to be angled or smushed together. And since the horizontal orientation is read from left to right, they may also be more intuitive for those with lower literacy. This bar graph does a few things quite well also. We have a title, a white background, so the blue and white contrast. Purple. On the printout it's blue. On the screen it's purple for me. So that's a good example of the kind of differing between settings on a computer or a screen. There aren't too many bars. So again, like the pie chart, limiting to 6. Try to keep, just a few bars if possible. Some features that could be improved, though, the acronyms might be confusing. So you see percentage of TBI survivors with PTS. That could be confusing, and a patient might not know what that is and might not even be able to remember what that is when they go home with their paper. And the percentages should be rounded to the nearest whole number. So the 30.8, 20.0, 8.4, rounding them up we talked about would be easier to recall and remember. Again, for bar graphs, do's and don'ts, use 6 or fewer categories like we were just talking about per graph when possible. The intervals should be regular and scaled properly without too many grid lines. Grid lines just make things look dense and messy. Also pay attention to your beginning and ending values to avoid distorting the graph or leaving too much empty space. For instance, if the x-axis only went up to 50, that wouldn't work very well if your measurement only went up to 25. So the idea here is, for this chart, everything is adding up to 100%, so having the chart go up to 100% works. If our measurement and things, whatever concept we were trying to get across, only went up to 20%, some of the data would be lost in the nuance of it being so low on the full scale. Sometimes bar graphs are overlaid with lines to represent statistical confidence intervals. This is really not recommended when we work with patients. The confidence interval gets confusing for them and dilutes the meaning of what we're trying to convey. There are also segmented and stacked bar graphs like this one shown here that compare the proportions to the whole. So instead of using a bar graph for this kind of concept, really we'd recommend a pie chart. So whenever everything adds up to 100, the pie chart is easier to grasp for patients. Line graphs are great for showing trends in data over time and often have days, weeks, or years on the x-axis. They're good for displaying before and after data, such as for treatments or interventions. They clearly show how numbers can rise or fall over time, and they are just a nice, easy way to look at data. This one gets a little confusing because it actually brings two disparate concepts within one line graph, so it might be easier for a patient if they were just pulled out into two separate graphs. As with the other charts, graphs and tables highlight key events and information with symbols and color. Again, pay attention to how your intervals and beginning and ending points are affecting your layout. Don't use more than 4 trend lines per graph, and if you can help it, avoid crowding with extra text or data. You can see here how they try to use an icon array at the data point, and that just starts to make the chart look busy and messy and confusing. So we'll talk just a couple minutes about icon arrays. These might be the least familiar of the visualizations that we covered. Icon arrays or pictographs are great for displaying probability data in the form of absolute risk. This is probably the kind of chart that the physician was talking about when he walked through risks of screening and breast cancer with his patient. When icons are built from the bottom up, they can illustrate risk using a height cue like a bar graph as well. So in this example, this was actually created on a website. It's a free tool, and the resources are in the back of this presentation called iconarray.com. It shows the absolute risk of developing cancer in women with the BRCA1 gene. Specifically, that 65 out of 100 women with the gene will develop breast cancer. So here you can see how it's easy to see the magnitude of that with the figures in a dark color, and they always recommend including all the figures. So you wouldn't stop at only the pink figures. You continue to show those that are unshaded as well. So the text is a bit small, but this is a kind of neat thing that you can start to use with your patients, and you can create your own visualizations. As with the other types, there are some do's and don'ts here. Consider using people-shaped icons that can humanize the data. I thought this was a funny graphic, too, but it was never addressed when you think of the female icon that we commonly use. So also think about that. You want to be cautious that you're not just representing men or women if it can be a condition that can be really experienced by the mass of population, and you don't want to insinuate that only 2 men can get it, so be cognizant of the type of visualization that you're using and the shape or the icon. Highlight the numerator, so in the last chart that we were just looking at, the pink figures represented the numerator. Place icons adjacently, so have them be in a symmetrical or orderly fashion, as we saw in the last description as well. And remember to keep your denominators the same, similar to what we talked about before, keeping the hundred the same, so 1 in 100 compared to 2 in 100 versus 1 in 100 compared to 2 in 50 or something like that. Here's another version of an icon array. You can see here where they're trying to bring in a lot of concepts, so be careful to not use too many symbols or colors within one icon array. And it's important to sometimes have numbers, but you want to make sure that the numbers don't distract from the simplicity of a graphic. So that is what I have for today. I'm going to flip through and then we'll get to your questions, but I wanted to highlight a couple of the resources that you'll see in the presentation. So the NIH has some resources that are really helpful when you're trying to learn more about numeracy and health literacy. Of course, you can go out to our website from the Minnesota Health Literacy Partnership. There are podcasts about health literacy and numeracy through Helen Osborne's website, Health Literacy Out Loud. They're fantastic. She interviews experts on the key topics that we've discussed today. There are resources and toolkits from the CDC. Here's the icon array, and there's another one called Viz Health where you can go out and create your own graphics. And then the two color blindness sites to, double check your color schemes as well. So I think we have a few minutes for questions, if anyone has questions. So I just want to thank you guys. I know that this can be a lot to soak in. And we went through a lot of material about numbers and concepts and visualization around numbers and numerical information, so I'm happy to answer any questions you might have.
Thank you, Alicia. That was a great presentation. Erin, can you remind everyone how to get in line to ask a question via the phone?
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7 to ask a question. And we do have a question on the line from Lisa Iverson. Lisa, please go ahead with your question.
No, I didn't have a question. I'm not sure how I got in the queue.
Okay, well, again, if you do have a question, please press the number 7 on your telephone keypad. Okay, we have a question on the line from Andrea Lewis. Andrea, please go ahead with your question.
Is there a way that we can print out this presentation?
Yes, the slides will be available on the LSQIN website after the presentation today. And I'll just put up, I'm going to get to the last slide here. Here's the contact information for the members of the Lake Superior Quality Innovation Network. And then the website is www.lsqin.org. And so the slides will be available at that website. And then you also can watch, and the recording will be available probably about a week or so on the website.
Great, thank you.
And I also want to remind everybody, if anybody had any questions that they prefer to type in chat, they can use that also. But we'll keep taking any other questions if people have them.
Again, if you do have a question, please press the number 7.
Doesn't look like we have a lot of questions today, which that's either good or that you covered everything, Alicia, or maybe people are still just mulling over everything right now.
I
Good, we got a question in chat.
I think it is hard just as our patients struggle with numbers and the numeracy concepts. As I was doing some research for this presentation, it does get to be a little overwhelming with all the different types and how you can express numbers in healthcare. So the graphic pieces, the remembering to round, we're already thinking of so much as we try to, educate and empower our patients. To have to throw in this, okay, now remember how you're going to talk about that number. It is difficult to do. So that's part of why we wanted to start to bring this topic forward. But it looks like there's a question. Is there any effort to make pill bottles easier to read? Oh, there are efforts around kind of trying to create some universal language around pill bottles, and some research has been done on using icons or symbols for times of day and those sorts of things to get rid of using 5 o'clock or 6 o'clock and trying to build that into people's daily lives and what they're doing and when it makes sense to take a medicine. I think, this is a common concern, especially when we're talking about outside of the number pieces, but warnings or, side effect labels that are, just pasted onto bottles, and there's limited real estate on a bottle. So things just get complicated because they're trying to make things almost too short, and then it becomes meaningless because you don't really know what they're talking about. As far as the numbers go, I think the idea of putting the numbers on the pill bottle is good. I've seen folks that come in with like a pill pack, and their doctor actually circles how many pills they're supposed to take each day on the pill pack. So there's a lot of, hands-on when we're working with patients. Pill boxes are a good idea to help with that too, kind of reducing, what do we keep saying, the cognitive burden for patients. So reducing the need for them to read the label over and over and just kind of put them in the pill pack for them. I think that prescription labeling is a big issue. Let's see. Oh yeah, so to print this presentation, so it'll be on the Lake Superior QIN website, and the link is right there. Eventually, it'll also be out on the Minnesota Health Literacy Partnership website. So if you, in a couple months forget where to, access the lsqin.org website, you can, go to the Minnesota Health Literacy Partnership, and we'll have it there as well. And as part of the partnership, we're really developing this as a toolkit for folks to use and to take to their own organizations. So we'll actually type out speaker notes as well. So you can just take it and use it and read it, tweak it to make it your own. But we really want to make it available for folks, even if you don't feel like you're an expert, because I don't think any of us really feel like an expert in numeracy yet. It's a newer concept. It's just coming to the forefront as a very important component of health literacy. So I don't really feel anybody feels like they're an expert, so we're just putting out the information that we've learned through our research. We were fortunate enough at the partnership to have an intern from the School of Public Health from the University of Minnesota who helped us with a lot of our research and fact-finding on numeracy to really pull this presentation together. But we will make it available. It'll have speaker notes as well on the website. So if you want to give it to somebody else, you would be equipped to do so.
Thank you, Alicia. And it doesn't look like we have any other questions in chat. Just want to check one more time to make sure there isn't someone waiting out on the phone to ask a question. Are we good, Erin? Or
there are no questions at this time.
Okay. Thank you, Erin. And I think with that, we'll give you back 4 minutes of your day and close out for the day. Thank you again, Alicia, for that wonderful presentation. And again, if anyone has any questions, feel free to contact any of us located there within the LSQIN, and have a great rest of the afternoon. Thank you.
This concludes today's teleconference. You may now disconnect.